So this is a video about Lodi taping, or at least a slightly modified version of it. Taping which takes its name from Dr. Ralph Dye, who is an American podiatrist. And Lodi is essentially tape which starts in the foot and ends in the foot. There is of course a high dye version which comes superior to the ankle, and there's also an augmented version which is a sort of combination of the two. Definite suggestions in the literature of superiority with respect to high dye and augmented versions over low dye, but that's probably for another video. We're not going to lean on the literature too heavily during this, going to try and keep it practical again, but there is lots of literature out there on low dye taping, and you certainly want to be looking at the works of people like Joel Radford, Cole Landorf, Anne-Marie Keenan and colleagues. Now from a personal point of view, although there are suggestions that are often made with respect to tape restricting motion of the foot or of segments of the foot, it's certainly not my goal when I'm taping a foot. Of course it may happen, but in my mind what I'm actually trying to do is change some of the forces rather than aim to directly change position. So it comes back to that kinetics, kinematics sort of topic area. Why do I use this? Well, I mainly use it for pain relief. Certainly if I don't think that someone will tolerate any sort of orthoses at that time. A really good randomized controlled trial in 2006 actually showed that low dye taping reduces that first step pain associated with plantar fascia symptoms, and I'd certainly say that my clinical experience with it echoes that. And of course the other main reason I use it is as a treatment direction test, in keeping with Bill Vincenzino's sort of 2004 manual therapy paper. Again, mainly for plantar heel pain, but also sometimes for patellofemoral pain as well. Definite caution to be advised when using tape as a TDT for foot orthoses, although there's a pretty reasonable suspicion that someone that does well with tape may do well with orthoses. Always got to remind yourself that taping is not orthoses. They are very, very different. Certainly the biggest criticism I've read previously is that tape works by applying tensile forces to the plantar surface of the foot, to the skin, whereas orthoses actually act by applying compression forces on the plantar foot. So they're pretty different in their mechanism of action. So just be wary about the promises that you make to patients. Even if they do well with tape, doesn't necessarily guarantee success with foot orthoses. So what follows here is my way of applying this tape, and I use a slightly modified version from the technique I originally learnt in this book here, which has been on my shelf around about 9 years or so. Really good book and worth a look if you do a lot of taping. But as I say, I use a slightly modified version, and certainly when I speak to friends and colleagues, it doesn't seem that any of us apply low dye tape in exactly the same way, and that would be echoed by the thousands of videos already out there as well. And it doesn't seem to really matter. So I'd encourage students, etc., to play around with this and find what works best in their hands. My way is certainly not the only way to do this. I certainly wouldn't profess it to be the best way, but it seems to be the best way for me, the thing that works best in my hands. So a short video follows of the actual technique. At the end of this video, my contact details. As always, I welcome feedback or comments or any sort of suggestions for future videos you may want to see along a similar or of course a different line. So I hope you enjoy the video and look forward to your thoughts. So I'll often position the patient in a supine position, and I'll ask them to gently dorsiflex their foot. I'm not too worried about subtalar joint neutral personally. And I'll start with my first anchor strip, which goes lateral to medial. You'll notice that I didn't stick down the end of the lateral tape at first. I do that second, and as I do so, I adduct the little toe and then apply that down. I'll just show you one more time because I always do 2 anchor strips, and also from this angle you'll see what I do medially. So again, lateral to medial, don't stick it down at its most distal lateral edge initially, strip it all the way around, and as you apply this part of tape, bring this plantar to the first met head. What that will do is help plantar flex the first ray. And again, the last thing I do, adduct the toe with my thumb and then stick down the lateral tape. Now the reason I do that is I found that athletes complain much less of any little toe irritation or sensations of pulling when I do it that way. Then, as with most Lodi techniques, we start applying some longitudinal strips. We start at the metatarsal heads and we move more proximally. Each time, with each subsequent piece of tape, covering the previous piece of tape by about 50%. Until the entire surface of the foot is covered. So while I'm waiting for myself to do that, a couple of the mechanisms by which this is proposed to work. There has been a suggestion that this sort of tape will increase the dorsiflexion stiffness of the medial column, which will in turn reduce the tensile forces in the plantar fascia and of course other plantar tissues. And also the suggestion this tape may well increase forefoot plantar flexion moments, which is thought to reduce the force needed to establish the windlass mechanism, which again is thought to be quite beneficial potentially in things such as plantar fascia pain. Another mechanism that I've got a gut feeling may be at play here is of course the tape immobilizing the calcaneal fat pad to a certain extent. You'll often find people with fat pad irritations quite like this sort of tape as well. So once that's all covered, we apply one more anchor strip over the top, not dissimilar to before, whereby we start lateral and we don't stick it fully down just yet, and we move to medial. But this time, instead of coming plantar to the first met head, we stick it medial to the first met head. So this is just a true anchor strap. Now I'll often, and again, adduct the little toe and stick that down laterally. I'll often ask the patient just to keep this on for 2 days. Paper by Yoho and colleagues in 2012 showed that this sort of Lodi tape will alter the deformation characteristics of the medial longitudinal arch, but only for 48 hours. Last thing we do, apply 2 adhering strips across the dorsum to keep the tape from flaying open as someone stands down. And that's the last single part I'll do there. So other than obviously discussing potential skin irritations and things, which hopefully you've done before you've put the tape on someone, that's about it. That's the way I would do it. Hope you enjoyed this technique. Be interested to hear if you do something similar or something wildly different. Contact details as always on the screen here. Feedback welcome. Next couple of videos coming up are already planned, one of which is also along the similar theme of plantar fascia symptoms, and a bit similar to my previous video with respect to chairside modifications for it, and also something else coming up regarding foot orthoses manufacture as well. So hope you're enjoying the videos and look forward to your feedback.